İyi akşamlar. Nasılsınız arkadaşlar? İyi misiniz? Haliniz, keyfiniz nasıl? Beğendiniz mi derslerimi? İnşallah beğendiniz. Some friends ask about coming here for living and working in Turkey. Believe me, Turkey is the most wonderful place in this world. But besides, they respect us as doctors very much. They are giving us the Turkish nationality. So, just you need to work hard to pass the STS exam and make the training period in the hospitals. To pass the STS exam, you must take this exam seriously as you are preparing for American exams or British exams. It is not easy at all. You must have a plan to pass this exam. You have to read and repeat every information as I said. Already I made the plan for you to pass the exam. Just you have to read this class and repeat it many times before the exam, and I hope you will succeed and make your dreams here if you want to come to Turkey. So I will complete here for gastroenterology for the third hour. For the gastric diseases. Now I will speak in English as I mentioned, then I will focus on Turkish language in the next slides. Epigastric pain. There is no definite way to determine the etiology of epigastric discomfort or pain simply by examining the history in the majority of cases. So, in the epigastric pain, the history is the most important thing. Epigastric pain can be formed from ulcer diseases, pancreatitis, gastroesophageal reflux disease, GERD, gastritis, and occasionally gastric cancer. Helicobacter pylori is most strongly associated with the development of duodenal ulcers, gastric ulcers, and gastritis, as we will see. Pancreatitis is the most common reason of epigastric tenderness and pain, seriously pain. Non-ulcer dyspepsia, a functional disorder in which there is persistent pain in the epigastric area and all the tests are found to be normal. Non-ulcer dyspepsia, that is not related to ulcers. So, the diagnosis of epigastric pain, the hardest question is when to perform endoscopy, which is often required for a definitive diagnosis. Barium studies of the stomach, such as the upper gastrointestinal series, are always less accurate than in endoscopy for problems in the stomach. When to do upper endoscopy in epigastric pain. All patients with epigastric pain and alarm symptoms, as I mentioned, such as weight loss, dysphagia, odynophagia, hem-positive stool, should undergo endoscopy. In addition, endoscopy is recommended for those aged more than 50 to 60, essentially to exclude gastric cancer. In general, if the patient is more than 50 years, we suppose do endoscopy. Endoscopy is also indicated in those whose symptoms have not resolved with the use of anti-secretory therapy such as PPIs or anti-H2 receptor blockers such as ranitidine or cimetidine. H2 blockers are only effective in 2/3 of patients. PPIs are more effective. Now, peptic ulcer disease. Peptic ulcer disease is the term applied to both duodenal ulcer and gastric ulcer, which it was mistakenly believed that the enzyme pepsin caused ulcer disease, but it is a wrong information. Etiology. Tobacco, smoking, alcohol, and the use of steroids by themselves don't cause ulcer disease. This is the most important information for the exam. The causes of ulcer disease is not related to the use of alcohol or smoking or steroids by themselves. It is related to NSAIDs, Helicobacter pylori, infection, cancer of the stomach, Zollinger-Ellison syndrome, Crohn's disease, burns, head trauma, or any situation that will lead to stress and prolonged intubation and mechanical ventilation. But the presence of smoking, alcohol, or steroids will make the peptic ulcer disease worse. But in themselves don't cause ulcer disease. So, tobacco and alcohol use can delay healing and are associated with the development of gastritis, not peptic ulcer disease. So, NSAIDs lead to ulcer formation because they decrease the normal production of the mucous barrier that protect the epithelial cells of the gastric mucosa. Prostaglandins, the major stimulant for mucus production that forms the protective barrier, are inhibited by NSAIDs, the use of NSAIDs, and hence diminish the protective barrier of the stomach lining. The mechanism of the formation of stress ulcers, like burns, head trauma, is that there is an intense vasoconstriction. So, in NSAIDs we have decrease of mucous barrier, but in stress ulcers we have vasoconstriction of the vasculate that supplies the gastric mucosa, leading to the starving of these cells and ulceration. Steroid use by itself doesn't lead to peptic ulcer disease, as I mentioned, and is therefore not a routine indication for stress ulcer prophylaxis. These steroids and alcohol tobacco will cause gastric, not peptic ulcer disease. We'll speak about this later. For physiology for the stomach, production of acid and other products in the stomach, we'll speak about these informations because they love it very much. Now, partial cells in the stomach produce acid, as we know. The three stimulants to the production of acid from the partial cells are gastrin, acetylcholine, and histamine. Three stimulants that stimulate the production of acid from partial cells. Gastrin is produced by G cells in the stomach, and its release stimulated by distension of the stomach or the presence of amino acids or vagal stimulation. So, gastrin will stimulate acid, the production of acid, but the production of gastrin will be stimulated by distension of the stomach or presence of amino acids or vagal stimulation. So, vagal stimulation also releases acetylcholine and gastrin releasing peptide. However, the single most important stimulant to gastrin release is the distension of the stomach, the presence of food, distension of the stomach. For the histamine is released by the endochromaffin-like cells present in the same glandular elements of the stomach that have the partial and sheath cells. Sheath cells release pepsinogen. So, histamine is released by enterochromaffin-like cells. Pepsinogen from sheaf cells, which is converted to pepsin by the presence of acidic environment of the gastric lumen. So pepsinogen to pepsin need acid. Histamine directly stimulates the partial cells to both release acid and potentiate the effect of acetylcholine. We said that the partial cells produce acid. Histamine stimulates directly the partial cells. As I mentioned, there is 3 stimulants for the production of acid: histamine, acetylcholine or vagal stimulation, and gastrin. Gastrin is stimulated by the presence of amino acids or distension of the stomach or vagal stimulation, acetylcholine. Histamine stimulates the partial cells to release acid and potentiate the effects of acetylcholine and gastrin on the partial cells. So histamine works directly to stimulate the partial cells to release acid, and indirectly by the potentiating the effects of the acetylcholine and gastrin to make it to work on the partial cells to produce acid. This is why H2 blockers such as simvastatin, famotidine, and trazodone inhibit acid release. So in Turkish language, esas hücre will be sheaf cells that release pepsinogen. Esas hücreli pepsinogen. Partial hücreleri, partial cells that release acid V and intrinsic factor. G cells gastrin. D cells somatostatin. Gastrin acid secretion stimuli ederken, the gastrin will stimulate the secretion of the acid. But the somatostatin acid vascular ve gastrin salınma engeller. The somatostatin will inhibit the secretion of gastrin and the acid. Engel prevent, vascular inhibit. So somatostatin will make no secretion of gastrin and acid. We'll talk about Zollinger-Ellison later, but here for G cells overproduction of gastrin, Zollinger-Ellison can be seen in stomach or pancreas or another places that we will talk about it later. But here in the stomach, Zollinger-Ellison syndrome is the excessive production and release of gastrin from G cells. Somatostatin inhibits the release of gastrin and histamine, as well as having a direct inhibitory effect on the production of acid from the partial cells. So the somatostatin will have direct and indirect effect to inhibit the releasing of acid. Now in Zollinger-Ellison we have more production of gastrin, so we will have more production of somatostatin to inhibit gastrin, but the gastrin is very high that the somatostatin will not be able to inhibit it. We will talk about later. Secretin is released from the S cells of the duodenal lining. Secretin, the main stimulant to the release of secretin is the presence of acid where? in the duodenum. The passing of acid into the duodenum will release secretin from the S cells. Secretin inhibits the production of gastrin, as well as stimulate pancreatic and biliary bicarbonate production and release. So the secretin will inhibit acid and stimulate bicarbonate from the biliary and pancreatic ducts. So the most common cause of ulcer disease is H. pylori, followed by the use of NSAIDs. 80 to 90% of duodenal ulcer and 70 to 60 of gastric ulcer are associated with H. pylori. Overall, 10 to 20% of ulcer are adiopathic and no clear etiology is ever identified. So we must keep in mind the physiology that I mentioned here for the cells of the stomach and G cells, S cells, and the releasing of somatostatin from these cells, because they ask about this very much. Clinical presentation of peptic ulcer disease. The most common presentation of ulcer disease is mid-epigastric pain. There is no definite way to distinguish between duodenal and gastric ulcer simply by symptoms. Of course, we can't distinguish by symptoms between the duodenal and gastric ulcers. The only way to be certain is with endoscopy or occasionally in radiographic studies with barium, and it will be rare, such as an upper gastrointestinal series. So the main way is endoscopy. But gastric ulcers have been associated with the pain on eating. So as I mentioned, the history of the patient will give us more information about the disease. For gastric ulcers, the pain will be on eating. For duodenal ulcers, the pain will relieved by eating. Because gastric ulcers were thought to be associated with pain on eating, this more frequently to lead to weight loss in gastric ulcers. And it's still necessary to perform endoscopy if a definite diagnosis is required. Tenderness of the abdomen is unusual with ulcer disease. Of course, when there is tenderness, we are thinking about perforation. So, in general, there is no tenderness in ulcer disease. More than 80% are not associated with abdominal tenderness in the absence of perforation. Nausea and vomiting are occasionally found with both gastric and duodenal ulcers. For diagnosis, ulcer disease is best diagnosed with upper endoscopy, as I mentioned. Barium studies are inferior. But in generally healthy patient age, less than 50 here with epigastric pain, endoscopy can be done after a trial of H2 blockers or BBIs. If the symptoms persist, then endoscopy can be performed. In those aged more than 50 or those with alarm symptoms like weight loss, anemia, hem-positive stools, or dysphagia, endoscopy should be performed. Now, diagnosis of H. pylori. I speak about the diagnosis of H. pylori because it is very important. The diagnosis of H. pylori is based on either serology, urea breath testing, stool antigen testing, or biopsy with histology. Knowing which diagnostic test to perform first for Helicobacter is not definitively clear. For serology, the least expensive, least invasive, and the most of easiest, and has a very high degree of sensitivity. So if there is H. pylori, the serology will be very sensitive, but negative test for Helicobacter antibody effectively excludes this agent as an etiology of the ulcer disease. So if serology is negative, we can exclude the presence of H. pylori. But if it is positive, we can't know if the disease is new or old. This is the problem with serology. The drawback to serology is that it doesn't really distinguish between old disease and new disease, and therefore lacks specificity. So sensitivity is very high. Specificity is very low because it can't distinguish between old disease and new disease. So specificity is low. In addition, neither serology nor breath testing nor stool antigen test can exclude the presence of gastric cancer because H. pylori can related to gastric cancer. The gastric cancer can be excluded with endoscopy. So the advantage of both breath testing and stool antigen detection method is that they have the same sensitivity as serology and are able to easily distinguish new versus old disease. So if I ask you for controlling H. pylori, can we depend serology? Of course not. Serology will be positive for all the life. But for controlling, we'll use breath test or stool antigen because they can distinguish between new disease and old disease. When H. pylori has been treated, both breath and stool tests become negative. This means that they can be used for evaluate eradication of the organism post-treatment and can test for cure of the infection. So for controlling, we use breath testing and stool antigen. For diagnose, we use serology. For a new versus old disease, we use breath testing and stool antigen. Biopsy with histology is the most sensitive and specific test for H. pylori. Further, it can exclude cancer. Now, histology and biopsy, we keep it to exclude cancer when there is alarm symptoms. 4% of patients with gastric ulcer disease have cancer. In addition, there is rapid test on the biopsy known as CLO test. CLO test, it can exclude Helicobacter pylori and is performed to see if the organism present in the biopsy specimen can produce ureas. So CLO test mean the presence of ureas in the specimen and it related to the organism of H. pylori. For this slide, we need two things. Which is the most sensitive? Which is the most specificity? The most sensitive duyarlılık sensitivity duyarlılık will be breath test, ure nefes testi, ure nefes testi. For the most specificity will be özgürlük will be urine FS test and culture. The culture and urea breath test. Urea test, urea test, histology, culture, ELISA for IgG, serology yani, urea nefes test. For treatment for H. pylori, the treatment of ulcer disease centers largely on the treatment of H. pylori. Use a PPI combined with clarithromycin and amoxicillin as a course. Omeprazole, lansoprazole, etc. are all equal in efficacy. The other two choices of antibiotics are tetracycline and metronidazole. So, PPIs with clarithromycin and amoxicillin or tetracycline and metronidazole. Bismuth is not necessary for the first step. Regimen that contains PPIs are superior to those with H2 blockers, such as ranitidine and cimetidine. More than 90% of patients' duration of therapy is for 2 weeks, but sometimes PPIs is continued with for a few months. In those who fail therapy, urea breath test should be performed to see if the reason of failure was the inability to eradicate the organism. So, if the urea breath test is positive, then the H. pylori was not eradicated. But if the urea breath is negative, then the patient has another disease. So, if the organism was not eradicated, then retreatment should occur with different antibiotics and the addition of bismuth. In addition, sensitivity testing for the organism should be explored. If the organism was eradicated and the ulcer persists, recurs, and worsens, the patient may need evaluation for other diseases like Zollinger-Ellison syndrome will be the most common cause for ulcers that will not heal for the treatment. Ordinary ulcers not related to Helicobacter pylori can be treated with PPIs alone. When we don't have H. pylori, PPIs can be given alone. Misoprostol is a prostaglandin analog that was developed to prevent the development of NSAIDs-induced ulcers. So, when we have NSAIDs-induced ulcers, the using of misoprostol is very beneficial. COX-1 is the enzyme that produces the prostaglandins that protect the gastric mucosa. So, the COX-2 is the enzyme implicated in the development of pain. COX-2 inhibitors were developed to relieve pain without damaging the gastric lining as much as NSAIDs. COX-2 inhibitors have no effect on palates. COX-2 inhibitors have no effect on gastric mucosa and have no effect on palates, such as celecoxib. Indication for surgery in peptic ulcer disease. Upper gastrointestinal bleeding not amenable to endoscopic procedures. Perforation. Refractory ulcers. Gastric outlet obstruction. So, when we have continuously bleeding, perforation, refractory ulcers, outlet obstruction, then the surgery will be needed. But in gastritis, the gastritis is the term applied to describe inflammation, erosion, or damage of the gastric lining that has not developed into an ulcer. So it is the next step of gastritis will be ulcer. But gastritis will be inflammation, erosion, damage of the gastric lining without ulcer. Steroid, alcohol, tobacco, as I mentioned, cause gastritis, but without ulcers. We have two types for gastritis or gastritis, gastritis in Turkish language. Now, type B gastritis increased in gastric acid. Unlike ulcer disease, gastritis can be caused by alcohol, as I mentioned, as well as NSAIDs, H. pylori, head trauma, burns, mechanical ventilation, etc. The types of gastritis from these factors is referred to as type B, which is by far the most common type of gastritis. So, the most common type is B. The causes are the causes of ulcers and alcohol, tobacco, and steroids. It's also associated with increased gastric acid production. There is increased in acid production. But type A gastritis, it is autoimmune maltoma, diminished gastric acid, elevated gastrin levels. So, in type A gastritis, there is atrophy of the gastric mucosa and is associated with autoimmune process such as vitamin B12 deficiency. Type A is also linked to diminished gastric acid production. Diminished. Here we have increased gastric acid. Here we have low gastric acid and achlorhydria. All patients with decreasing of the chlor or achlorhydria will have markedly elevated gastrin level because acid inhibits gastrin release from G cells. MALT, mucosal associated lymphoid tissue, leads to metaplasia as well as possible dysplasia and then gastric cancer called maltoma. We'll talk about this in other section. So, I will focus on gastritis in Turkish language because they love gastritis in the exam. Acute gastritis. Superficial gastric mucosa. In the superficial gastric mucosa, neutrophil will be an acute inflammatory uli. So, the white blood cells will be arise in neutrophil. Acute gastritis, cyclically erosive hemorrhagic. The acute gastritis will be erosive and hemorrhagic. Now, these informations are very important. Pathogenesis, medulomucosa. There is zidelmency, busal muscle, damage of the all of mucosa of the stomach, all of the mucosa. But doku derinliğine daha az olmasıyla, but not in deep tissue. So all the mucosa without deep layers. Now, gastrin increase. Perfusion will be decreased. Focus on this slide to know the levels of gastrin, perfusion, and mucus. Gastrin increased. Perfusion decreased. Mucus decreased. In acute gastritis, we have a type of acute gastritis called acute suppurative gastritis, and the cause is Staphylococcus. Other type is acute phlegmanos gastritis, and the cause is Streptococcus. So, in acute gastritis, we have neutrophil, but in chronic gastritis, we have lymphocyte, the plasma cells. Aspirin and alcohol, as I mentioned, are equal to make acute gastritis. Chronic gastritis mean lymphocyte and plasma cells infiltration. Now, partial ve Sheaf cells, أساس حجرة, sheaf cells will be lost in chronic gastritis, not acute gastritis. This is exam question. Which is the cells that will be lost? What are the cells that will be lost in chronic gastrite? Partial and sheaf cells. Mucosa will be atrophic, and we maybe see intestinal metaplasia. H. pylori, insect, it will be the most cause of the chronic gastritis. The disease will be in antrum and the body of the stomach. Antrum and the body. H. pylori, hypertrophic infectious gastritis. The type of the chronic gastritis of H. pylori will be hypertrophic infectious gastritis. This lesson is a little hard because it's information just you need to keep in mind. As I mentioned, focus on this slide and this slide. For gastrin in acute gastritis, perfusion and mucus. As I mentioned, we have two types of chronic gastritis. It will be A and B. B will be for NSAIDs, H. pylori, steroid, alcohol. In the antrum, it will be affect the antrum and not the fundus or corpus. Type B. The acid will be normal. The gastrin will be normal. The insect, the most common cause is H. pylori. Gastrin yapan hücreleri karşı antikor olabilir. We can see antikor against karşı the cells of gastrin in B tip, and it will be usually cell superficial. For A tip, fundus and corpus, the antrum is korunmuştur. It's not affected. It will be not affected. It is autoimmune gastritis. There will be anticore to partial cells. Here for gastrins yapan cells, for G cells. Here for partial cells. The gastrin in type A will be high. As it is autoimmune, so we'll see pernicious anemia, the presence of pernicious anemia, B12 deficiency, because there is anticore for partial cells. Hypo via achlorhydri. There is decreased or no presence of chlor. Diğer autoimmune hastalıklarla birliktelik, it may be occur with other autoimmune diseases. Tüm katları tutar. It will affect all of the layers of the stomach, not like the B tip. This slide is very important, very important. So I mentioned here a general information, but in this slide and this slide and this slide you have to keep it in mind because they love these informations. Hangi hücre? What are the cells that affected in A and B? What are the anticore against for hangi hücre? And antrum, fundus, corpus. Antrum in A is not affected. Antrum in B is affected. A is deep, B is superficial. The cause in A is autoimmune. The cause in B is H. pylori is the most common cause. Then NSAIDs, alcohol, tobacco, etc. The gastrin will be normal in B tip and it will be high in A tip. Now we can see gastritis in immunitmes in immune deficiency like CMV, Candida, herpes virus, avium intracellular, T. pallidum, tuberculosis. So immune deficiency gastritis. Minter hastalığı, Minter disease, mide mucosası massive genişlemiştir. The mucosa of the stomach will be wide and destination in the mucosa, strengthen in the mucosa. Hypertrophic gastritis, hypochloride, mideden protein kaybı, the loss of protein from the stomach, weight loss, kilo kaybı, weight loss, karın ağrısı, abdominal pain. So the most important thing here is mucosa will be hypertrophic and hypochloride. Now I will focus on type A, type B chronic gastritis. As I mentioned, in type A, antrum is not affected, but corpus and the body or fundus. In type B will be antrum. Etiology, type A autoimmune, anticore for partial cells. Here it will be H. pylori, NSAIDs, steroids, alcohol, tobacco, stress ulcers, the causes of stress ulcers like head trauma, burns, etc. Type B is more common. Inflammation will be atrophic, deep of all the layers in type A and it will be superficial in type B. Acidity, there will be achloride with decrease in acidity. Gastrin will be increased in type A and will be normal in type B. İlişikli durumlar, the situation that came together with type A will be with resistant anemia, mede ulcer, mede carcinoma. But in type B will be dyspepsia and ulcers. Yoğun bakımdaki hastalara sucraloft verilme nedeni aşağıdakilerden hangisidir? What is the reason of to give sucraloft for the patients in ICU? Yoğun bakım, ICU, intensive care unit. The effect of sucraloft will be increased the BGE2 synthase, BGE2. It will increase the perfusion of the stomach. It will increase the secretion of mucosa. It will decrease the acid and increase the pH. So if we came to here, mucosal yanlış, wrong, because mucus will be increase. Mucus secretion will be arter, increase. Acidity arter, there will be decrease, not increase. Arter, increase. Azalmış, decrease. pH 4'ün üzerinde çıkar. To rise the pH more than 4. So this is yalnız this is the true, because mucus will be increased and acid will be decreased. Now the efficacy of H. pylori and the ilişkinin derecesi, the related degrees for duodenal ulcers will be the most effective. Gastric ulcer a little more, gastric cancer more little, gastric behavioral lymphoma of B cells of the gastric, will call it maltoma. This is very important information. We'll study this in other part. Maltoma, the cause of maltoma will be H. pylori. Non-ulcer dyspepsia, it can cause non-ulcer dyspepsia, but it can't cause esophagitis or GRD. Non-steroid anti-inflammatory ilaçlar, the medication NSAIDs ve gastrointestinal system. So it will inhibit the enzymes of cyclooxygenase. PGI2 mide asit salgısını azaltır. The PGI2 will decrease the acid secretion in the stomach. PGE2 and PGF2 mide ve ence bağırsakta koruyucu etki olan mukas salgısını artırırlar. They will increase the secretion of mucus that will protect the small bowels, ence bağırsak, small bowels and the stomach. Aspirin ve NSAID alımı ile mucosal prostaglandinler azalır. When we take aspirin or NSAIDs, the prostaglandin will be decreased for the mucosa. Duodenal ve gastric ulcer komplikasyonlarının incidence artar. There will be increase in the incidence of complication for gastric and duodenal ulcers by the using of NSAIDs. Rectal kullanmaları OST-GIS yan etkilerini engellemez. They will be not protection by the using of NSAIDs by rectal way. Peptic ulcerden korumak için PPIs veya misoprostol birlikte kullanılabilirdir. So we can use misoprostol or PPIs to protect peptic ulcer disease when we use NSAIDs. Uzun süreli peptic ulcerli hastalarda in the patient with peptic ulcer disease for long time, uzun süre NSAIDs kullanımı öncesi, before we use NSAIDs for long time, H. pylori eradicate edilmeli. We have to eradicate H. pylori. Diyareye yol açan enteropati veya kolit ulaşabilir. NSAIDs may lead to colitis or diarrhea. So the most important thing here is NSAIDs bağlı ulcer gelişiminde risk factor. The risk factors that will develop to ulcers that related to NSAIDs. More than 6 years peptic ulcer history hikayesi, NSAIDs kullanımına asit yan etki hikayesi ait يعني اتكي حكاسي a history of side effects that will be related to the using of NSAIDs aynı anda corticosteroid kullanımı and the same times we are using steroids yüksek dozda veya çeşitli NSAIDs when we use more than one drug of NSAIDs or high dose of NSAIDs yüksek dozda. When we use COX-2 inhibitors, the peptic ulcer disease occurrence will be very low in düşük as cycloxib, rifoxib, etc. So, clinical presentation of gastritis. It will be asymptomatic bleeding in the most of patients. When the gastritis is severe and erosive, patients will have abdominal pain in the same area that patient with ulcer disease. Because the ulcer disease is the next step of gastritis, so they will have symptoms in the same place. Nausea and vomiting may also cause any symptoms of the stomach, hematemesis, melena, etc. Now, diagnosis and treatment of H. pylori is the same as for gastritis and peptic ulcer disease. Vitamin B12 deficiency and precious anemia are initially diagnosed with low vitamin B12 level and increased methylmalonic acid level, and we'll study this in hematology. How to diagnose B12 deficiency anemia. The diagnosis of pernicious anemia is confirmed by the presence of anti-partial cells antibody for here in chronic type A gastrite, anti-partial cell antibody and anti-intrinsic factor antibody. It's treated with B12 replacement, as are all cases of vitamin B12 deficiency. Now we'll speak about Zollinger-Ellison. I think I don't have much time to speak. We'll take this case and we'll stop here because you have a lot of informations about Zollinger-Ellison. 42-year-old woman comes to your office with complaints of diarrhea for 6 months. She has stopped all dairy products, but there has been no improvement. There is no blood or pus with the stools. She takes maximum dose of omeprazole daily along with famotidine and still has ulcer symptoms. She has hypercalcemia. What is the next step for the evaluation of the patient? Now, before continuing for Zollinger-Ellison, for the stomach and gastritis, the slides that I gave you in Turkish language are very important, and you have to keep them in mind. They are a little hard, but believe me, if they focus on gastroenterology, there will be 1 or 2 or 3 questions for gastritis type A and type 2, and how gastrin levels will be, and antrum, corpus, fundus, where to affect, and use superficial or deep. This slide will be very important, as I said. This slide and this slide. And for acute gastritis, this slide is very clear. The increasing of gastrin in acute gastritis, the increasing of gastrin in chronic A type, and in B will be normal. The levels of gastrin are very important in the 3 types of gastritis: acute gastritis, chronic A type, chronic B type gastritis. So in this case we have diarrhea for 6 months and the patient has taken all dairy products. There are refractory ulcer symptoms. The patient took famotidine and omeprazole. So, a long-standing ulcer, a long-standing diarrhea, but hypercalcemia. From where hypercalcemia came? In Zollinger-Ellison there is no hypercalcemia. From where hypercalcemia? As I mentioned, there are keywords in exam. When to have hypercalcemia in Zollinger-Ellison? In endocrinology, we'll talk about MEN syndrome, MEN 1, MEN 2A and B, MEN 3. In MEN 1, we'll have 3P, pancreas tumor, that will be Zollinger-Ellison, and pituitary tumor, and hyperparathyroidism, that will be responsible for hypercalcemia. So in general we can see with Zollinger-Ellison the symptoms of hyperthyroidism and pituitary gland. So keep this in mind. This case you will notice that hypercalcemia here refers to hyperparathyroidism. So Zollinger-Ellison syndrome onda, in the syndrome of Zollinger-Ellison, pancreas G-renin neoplasia C. There will be neoplasia of the G cells of the pancreas. Hypergastrinemi, there will be hypergastremia. Hyperacidity, there will be hyperacidity. Multiple duodenal ulcers, multiple jejunal ileal ulcers, esophageal ulcers, diarrhea, malabsorptions. Zollinger-Ellison tumor localization Gustrim the endoyalurium, as I mentioned. Please don't forget this. For the staging and local spread for the tumors like Zollinger-Ellison and esophageal tumor and duodenal tumor and gastric tumor, the the way to diagnose is endo-ultrasonography. Now, malabsorption in Zollinger-Ellison. Why malabsorption? There will be diarrhea, and after a few minutes we'll speak about the cause of this. Before this slide, I will speak about Zollinger-Ellison syndromunda aşağıdakilerden hangisi görülmez? What we can't see, it can't be seen of the following in the syndrome of Zollinger-Ellison. Sekretin ile baskılanamayan aşırı asit salgısı, the secretion of acid, severe secretion of acid, aşırı severe secretion of acid that will be not inhibited by secretin. Açıklanmayan diarrhea that is not the cause is not clear. Anastomosis ulcers, toxic acid secretion, high acid secretion level secretion, primary jejunum ulcers. I think it is a little bit easy because anastomosis ulcers, will not came here, it came in surgery, after surgery. So Zollinger-Ellison sendromu pankreastaki G hücrelerin malignant transformasyon sonuç oluşur. A transformation to malignant from G cells in that will be in pancreas. İnsülinomalardan sonra en sık rastlanan adacık hücre tümör. The next after the insulinoma, the next common cause of malignancy in the islet cells of pancreas. Multiple endocrine neoplasilerde en sık bu adacık hücre tümör gözlenir. In the multiple endocrine neoplasia will be the most common islet cells tumors. We'll see hypergastrinemia, hyperacidity, primary duodenal ulcers or gastric or ileal esophageal duodenal ulcers, sekretin ile baskılanamayan asit salgısı vardır, as I mentioned. Secretin will be very high in Zollinger-Ellison because all the time acid will be high. So all the time secretin will be high because all the time acid will be passing from the stomach to the duodenum, and all the time there will be secretion of S cells in the duodenum for secretin. So there will be more secretion of bicarbonate from the pancreas because of the secretin, and this is the cause of diarrhea. So secretin will be high to inhibit acid, but it can't be able to inhibit acid. So I think we'll stop here and we'll complete for Zollinger-Ellison in the next hour. But the very important information here for Zollinger-Ellison is BAO to MAO is more than 0.6. This is very important question. I will talk about this and complete for Zollinger-Ellison in tomorrow. I hope that my lessons will be useful for you to pass the CTC exam, and in this class your plan will be ready for passing the exam. This information that I am giving you are very important, and I gather them from many books from Turkish language and English language. So I hope you interest this class, and as I mentioned, after every section, after this section in gastroenterology, I will make keywords to make action to this class and make it more fun. Kendinize iyi bak arkadaşlar. İyi geceler.